I am Dr. Janice Williams. This lecture will cover history taken with a focus on history taken for the advanced practice nurse. In this lecture, we will cover three areas: the interview process, how to effectively communicate, and I will give some examples of ineffective communication, and we will also talk about the narrative. The objectives of this lecture is to explain how the advanced practice nurse should effectively obtain and synthesize the information necessary in an evidence-based comprehensive health history. In this lecture, we will also identify the 7 facets of health. We will explain the 4 steps in the interview process. The lecture will conclude by explaining the 13 components that should be included in your comprehensive assessment of your patient. Let's start out by talking about the 7 facets of health. When we talk about the 7 facets of health, it is when the advanced practice nurse looks at their patient through the lens of the holistic model. So it's not just looking at the physical, which is how the body adapts, but it's also looking at the emotional. What are the attitudes, the mental fitness of your patient, while also considering the social well-being of your patient, which a patient's social well-being is contributed not only to the patient, but it's those family members and friends that provide a supportive relationship. It is also looking at the cultural influences, positive inter and intra-professional influences that promote good health, while considering spiritual influences. What is the patient's sense of moral, ethical, and peacefulness? What contributes to a peaceful life for your patient? Is there a spiritual component to it that needs to be included as you're considering and collaborating with your patient on their healthcare plan? Looking at the environmental influences, both positive and negative. And then finally, the last facet, how does one think? The developmental level of your patient. How do they problem solve? What are their coping strategies? How do they make decisions, and how can you assist them and collaborate with them to make the best decisions for their health? Now let's break it down to the 4 parts of the interview process. These parts include the pre-interview, the introduction, the working aspect of your interview, and then the termination, the final aspect. How are you going to end your interview or your interaction with your patient? So let's talk a little bit more detailed about the pre-interview. The pre-interview is where you, the clinician, take the time to prepare for your encounter with your patient. This may be done the night before. It may even be done the day of, but prior to your patient entering the encounter with you. This is where you, the clinician, review maybe the documents, the electronic medical records of your patient, where you evaluate and make sure that the exam room is conducive to the encounter in which you are going to be providing for your patient. And that you also take consideration to your personal appearance, that you are appropriate, and that you are prepared to interact with your patient by either taking notes, having your whatever supplies that you need for this encounter. But it's the pre-work. It's getting ready. It's preparing you. It's also going to help you to save time when you have your actual encounter with your patient, because healthcare providers have limited time. So your pre-interview is very important. Part of your pre-interview is also where you can pull in your healthcare team, your medical assistant, your nurse, maybe even your social work if necessary, to have a conversation about what the care plan for this patient may be, where you think the care should go. Of course, once you have your encounter with the patient, you will collaborate with that patient to determine what the final care plan will be. When you are preparing for your encounter with your patient, it's an important component of that preparation is preparing to have a conversation with your patient that will help you build rapport. When we think about that, there are 3 tenets that can help you to prepare and build a foundation to build rapport with your patient. The first one is develop. It's as you conversate with your patient, you have to build trust between yourself and your patient. This comes with allowing your patient to feel like they're in a safe space, to conversate with you and to give you information, to tell their story. And then as they tell their story, that you respect the story that they're telling you, and you then help to collaborate with them by applying your knowledge, which will come from your objective findings as well as your physical exam. But they need to feel like they have a safe space. Also recognizing that another tenet is the discover aspect. This is the part where you as the clinician recognize that you don't have all the information. It is your job to try to discover information that would help you develop the best plan for this patient that is sitting in front of you. And then you conclude with the third tenet, which is to provide guidance to your patient. What is it that you believe with collecting the information from your patient and your assessment that will provide your patient with the best level of wellness? In order to do this, it is important to make sure that you are collecting an accurate history. This may sound like a lot for you as a clinician. However, the way you as a novice clinician gets better at doing this is practice, practice, practice. Practice with your friends and family on interviewing, utilizing your skills that will help you build rapport. And we will talk about that a little later in this presentation when we talk about effective communication. It is also important as a new clinician to recognize that when you first start and begin your practice, it takes time to develop a ease in which you interview your patients. So a strategy that can help you to continue to develop your interviewing skills is to maybe make a checklist so that you know where you want the conversation to go and that you can ensure that you're collecting the information that you need to help provide your patient with the best level of care. And the more that you prepare a checklist in the beginning as you're learning to be a clinician, you will then get to a place where you can have conversational interviewing. That is where you're able to just have a conversation and you can glean the information from your patient just by having a regular conversation. But this is all built on the strategy of developing a plan, which I like to say is a checklist, and then being prepared for your interview with your patient. And if you have any type of mnemonics or special strategies that help you to remember what you need to cover in your interview, this is where you start to prepare all of that in your pre-interview. But preparation is key. As you've probably heard before, if poor preparation, poor performance. I like to say prior preparation prevents poor performance. Now let's move on to your introduction to your patient. So you've prepared for your patient before you've gone into the room. But when you introduce your patient to yourself to your patient, it is a requirement that you appropriately present yourself to your patient. And what I mean by that, you introduce yourself with your professional title. As a student, you'll say something like, "Good morning. I am nurse practitioner student, Mrs. Williams. I will be working with my preceptor to take care of you today. How would you like me to address you, Mr. Williams? You are Mr. Williams?" And they may say yes or no. And then you address your patient as they desire to be addressed. Before you proceed with any more questions, be sure to identify and make sure that your patient, that you are speaking to the correct patient. There could be 3 Mr. Williams on your schedule that day. So you want to verify date of birth, social security number, something. You want to use a second identification tool to ensure that you are working with the right patient. For myself, I go and I say, "Good morning. I am Mrs. Williams, the nurse practitioner who will be taking care of you today. I see here that I have Mr. Williams," and they will usually say yes. And I will say, "Well, how would you like me to address you, Mr. Williams?" And they will tell me, "Oh, you can call me Mr. Williams." And I say, "Great, I will do that. And before we get started, can you give me your date of birth? I just want to confirm that I have the right Mr. Williams in the room." And then they'll give me their date of birth. And then before I get started with any more conversation with the patient, I'm going to go ahead and wash my hands, and then we're going to get started. And maybe while I'm washing my hands, I ask the patient, "Can you tell me what brings you in today?" I make sure that when I'm asking my patient questions, that I am paying attention to what the patient is saying. I know that we have to document. I know that we have limited time. But you want to make sure in that introduction that you are being attentive to your patient. You can do that by simple things, making eye contact, reaffirming. So make sure in the introduction that you show that you are present with your patient. Because remember, as I mentioned earlier, it's important to build that rapport. And if you do not show yourself as a clinician who's attentive to the patient's needs in the beginning of the interview, it is very hard to recover from that later on, or to get your patient to open up to give you the information that you may need in order to provide them with the best care. So as you are having or still in the introduction phase of your interview with your patient, a communication technique that will assist you in building rapport and acquiring the information necessary to provide the best level of care to this patient is learning how to ask open-ended questions and questions that are patient-centric. When we say open-ended questions, it's questions like, when did you last receive your flu vaccination? What brings you in to see me today? Instead of using closed-ended questions like, did you get your flu vaccination today? I see that you're here for your hypertension. Those are kind of closed-ended. But if you ask open-ended questions, it allows the patient to feel like they are the center and that you are focusing on them and allowing them to be a part of this process. Also, when you think about your introduction, helping the patient to recognize that you consider them the center of this encounter is very helpful. We talked about how you introduce yourself, how you acknowledge how they would like to be identified, and that you acknowledge that it is your pleasure to be able to take care of them. I myself use the communication skill with each patient before I end my counter. I was like, it is my pleasure and my honor to be able to take care of you today, that you chose to come in to see me. And that seems to allow the patients to recognize how important they are to this encounter and to me as a clinician, and that I recognize that they could have chosen to go and see any other clinician, but they chose to come to see me. Now let's move to the working phase. So we talked about the pre-interview stage, your preparation. We talked about the introduction, making sure that you provide the patient with an understanding of who you are, which will include your name, your position, your title, and then that you will then move to the working phase. This is where you allow the patient to tell their story. We know that to be what we call the subjective information that we collect during the interview process. but I like to call it their story. It's them telling us what brings them in, how they feel about themselves, how they feel what's going on with them. And then you also include in that the objective phase. That is where we collect the data from our purposeful examination, our diagnostic test, and then we put the two of these pieces together to help to develop a plan for our patients that will enhance their well-being. And then we move from the working phase to our termination phase. This is how are you going to conclude your visit. Thank you so much for coming to see me. Can be just that last closing statement, but it's also summarizing for your patient what it is, what is the plan that you and the patient have come together to collaborate on for that patient. And remember, it's a collaboration. We no longer practice paternalistic medicine. It is now a relationship and a collaboration between the patient and yourself. And we're going to talk more about the components of that, but make sure that you go through the pre-interview, the introduction, the working phase, and then the termination phase. What I'd like you to do is take a minute to stop this PowerPoint and look at these two videos. One video shows you good communication. The other video is going to show you poor communication. This will help you to kind of reflect on what kind of communication do you provide to your patients, and then help you to see the impact of what poor communication does to a patient and what positive communication does. So take the time, click on the link that says communication part 1 and then communication part 2. And then once you've watched it, come back to this video. Now, as you've seen through those videos, it showed you some communication techniques, both bad and good. I would like to take a little bit of time to just talk about good communication strategies, such as active listening. This is where you focus your listening on the patient's story. You also pay attention to the patient's body language. You look at the patient in the context. And when I say context, you're evaluating what does their facial expression show? Are they dressed appropriately? Are they responding appropriately? But where you actively listen, and as you can see from my cartoon here, is look at what the provider is doing, but look at your patient. So it's important. I know that we are in a technological world, but that we are not, what I like to say, treating the computer and not treating our patient. And again, as we mentioned earlier about the importance of open-ended questions. Learning how to communicate using open-ended questions will help you as a clinician save time. If you use more closed-ended questions, it is going to require you to ask more questions. Whereas if you use open-ended questions, you can often glean a lot of content, a lot of information from your patient that will help you, and you won't have to keep repeating questions. When you're communicating with your patient, it takes time to learn how to avoid using leading questions. And so you may ask, what is a leading question? A leading question is that question, if you think about it, where you ask, you're not having any chest pain, are you? Your legs aren't swelling? Your patient will answer probably no to those. Those are leading. So you're telling the patient, kind of leading them into giving you the answer that you want. Whereas if you use a good question, it'll say, when was the last episode of chest pain? Tell me what symptoms you are experiencing. That provides the patient to feel like they have a safe space to give you the information that will help you to appropriately assist them and treat them. It is also a good communication technique to ask clarifying questions. If the patient tells you something like, I just don't feel well, you can say, can you elaborate on what you mean about I don't feel well? Or you can also use a good technique with communication, which is reflection. The patient says something, you reword it and you repeat it back to them. This helps to clarify if you heard them correctly and if what they are saying is what you are interpreting, if you're interpreting it correctly. So the use of reflection is a wonderful communication technique. Another communication technique is expressing empathy, acknowledging the patient's feelings, acknowledging what the patient is saying. And if appropriate and when appropriate, you may have to stop the interview process that you have established from your pre-interview, maybe checklist, to address the needs that the patient has. If your patient comes in and they're crying, they're upset, or they tell you that a family member just died, even though they're there for their high blood pressure medication refill, you may need to take time to express empathy and acknowledge what the patient is saying to see if there's anything you can do and to help validate that what they're feeling at that moment. Reassurance and summarizing what the patient says is very effective, which we discussed earlier. And then, as I mentioned, sometimes you may have to address the needs of the patient. Maybe your patient comes in and English is their second language. So you may need to use the communication technique of accommodating. Maybe you need to take the extra time and get an interpreter. Or maybe they're hearing impaired, so you need to get resources so that they can clearly hear what you're saying. Maybe they have cognitive impairment or some type of mental emotional disturbance. Maybe there is a need for either a family member or a caretaker or someone to be in the visit with them. Or if they're not there, maybe having communication with your patient, and you must get approval to say, hey, I know that so-and-so helps to take care of you. Would you like me to call them or send information for them so they will understand what we talked about today? Taking that time to pay attention to your patient and their needs and recognizing that sometimes the patients may come in and you may have to go the extra mile to make sure that you're providing the best care for that patient. Now let's transition that we've talked about the pre-interview. We've talked about the introduction. We've also talked about the working phase and the termination phase. So the different 4 components of the interview. Let's go in and talk about a little bit more detailed about what is the narrative. As an advanced practice nurse, you are going to be required to document information so that you can tell the story of why you're going to make the assessment, which is your diagnosis, and the treatment plan that you're going to be recommending. So there are some factors that should be included in this narrative. These factors consist of the chief complaint, history of present illness, medications, allergies, the medical history, the surgical history, family history, social history, sexual reproduction history, health promotion and immunizations, and the review of systems. When you collect these factors within your narrative, you then can go to your assessment and make an appropriate diagnosis for the patient, and then develop a comprehensive collaborative treatment plan for your patient. So we're going to talk a little bit more about what each one of these factors should look like in your narrative summary. Let's start off by talking about the chief complaint. When we talk about the chief complaint, this is the reason the patient says is why they came in for your visit. Your chief complaint should be in quotations, in the patient's own words. So if the patient says, I'm here for a medication refill, in quotations, your chief complaint should say, patient reports, and in quotations, here for a medication refill. Then you move to your history of present illness. In the HPI, which we call the history of present illness, is where you get a more detailed explanation of the patient's chief complaint. We often use the mnemonic old carts. Old carts is when you talk about the O for onset. When did this start? L is for location. Where is it located? C is for characteristics. Describe the quality of the symptoms. A is for aggravating and associated symptoms. What makes it worse? Or any other associated symptoms. R is for relieving factors. What makes it better? T is for timing. When did it start? How long does it last? S is for severity. On a scale of 0 to 10, how severe are your symptoms? So let's just take a very simple example. Patient tells you they're here for a follow-up on their hypertension. This is your first time seeing the patient. How can you apply old carts to that? You can say, well, when were you first diagnosed with hypertension? The patient may say 2 years ago. Who diagnosed you with hypertension? Oh, I was seeing a provider at Kaiser. And have you had any problems since you've been diagnosed with your hypertension? And then the patient may say, no, everything's been fine. And then you go into, are you taking your medicines every day? Or are you on medications? And the patient can say, yes, I was prescribed a medication. Are you taking your medications every day? Yes, I am. When was the last time you took your medications? Oh, I take my medications in the morning. Wonderful. Do you check your blood pressure at home? Yes, I check my blood pressure at home. When was the last time you checked your blood pressure? Oh, I checked it 2 weeks ago. Do you remember what the reading was? This is where you can accumulate all of that information, even for a patient who comes in with no major complaints, but how your HPI can tell the story for you from your perspective and from the patient's perspective. So you put the two together. Then let's move to allergies. When you think about the narrative for allergies, you want to ask specifically to your patient, do you have any allergies to medications, foods, latex? I even often will ask the patient, how about any issues with anesthesia? And I will put that under my allergy section. You then transition to ask about medications. Are you on any prescription medications? Any over-the-counter medications? Any supplements or herbals? Any illicit substances? Any vaping? Any marijuana use? I ask all of that there because don't forget, they may have a marijuana card, but I specifically ask each one of those categories under medications and I document the answer to that because this can change. It is also important to ask all of these questions because if you just ask about prescription medications and your patients are taking a lot of herbals, those herbals may interact with your prescription medications. So it's important to know. And then sometimes patients may be taking medications from over the counter that go by a different name. Maybe they're used to the brand name and then they had a prescription for it, the generic name. They don't recognize they're using the same medication. So this will help you to understand that. It'll also help you as you go through your physical exam, or even if they came in with a complaint. Maybe it's due to the interaction of the medications together. So it's very important to be comprehensive in gathering this information. For patients, you may have this information already have received it from your pre-interview, right? You looked at the chart, you saw what medications they're on. It is appropriate for you every time you see your patient, not to ask the patient, are you still on all the same meds? But to be specific, because what does that mean to a patient? Now let's transition to the past medical history and your surgical history. When we talk about the past medical history, what we're looking at is them actually telling you what they know that they've been diagnosed with. Because sometimes what patients remember or what they understand can be different than what you see on the chart. So this is where you can validate that. Oh, I've been diagnosed with high blood pressure, but maybe they're on a cholesterol medicine. And maybe they didn't remember or didn't understand what that medication was for. So asking specifically, what medical diagnosis do they have? Did they have any childhood illnesses? If so, you want to document it, and if they can remember the year. If not, that is okay. But with the medical diagnosis too, it's a good strategy to document. If a patient says they had hypertension, how long have they been diagnosed? How long ago were they diagnosed? If they had diabetes, when were they diagnosed with diabetes? Because it also may help you in preventative. If you have a new diabetic who was just diagnosed maybe a year ago or 6 months ago, the patient education that you may need to do with that patient may be more than someone who had diabetes for 10 years. You also want to ask about their surgical history. Have they had surgeries? If so, where and when? And the reason, if they can remember. And you want to document that. Some of this may already be documented in the chart for you, so it's just a review with the patient. And the reason I review this information, you want to make sure it's accurate. You're not always sure that the information collected was done correctly, or maybe the patient stated one date and it really was something different, and later on they remembered, oh, you know what, I did tell that last provider it was in 2010, but it really was in 2015. And then also, again, you could ask here or in the allergy section about anesthesia. You then move to your family history. When I'm asking patients about family history, I do 2 levels up and a level down. What I mean by that is, for each patient, I ask them about their parents, their grandparents, both maternal and paternal. When I ask them about their health, then I ask them, do they have siblings? And I ask them about children. If you stop this lecture, there is a link to where you can go to look at family genograms. If you have not heard of what a genogram is, please click on this link. This is one of the best tools to actually do basically a family tree that can show you the medical history of your patient's whole family. You can plug that information in, and then you can have a visual of what that patient's family history looks like. Why is that important? It's important when you think about preventative care, because we know that some things can be passed down from genetics. So take some time and click on the site and look at how to utilize a genogram. Once you've completed your family history, you also then want to go to social history. Social history has many components. You can see here, you want to ask about their tobacco use, which may include vaping, and then you want to document packs per year. If you click on the link, there's a tool that'll help you do that if you've never done that before. You also want to ask about alcohol use. And depending on what your patient's response is, you may want to use one of those screening tools. And you do that as necessary. Remember, these are screening tools. These are not diagnosing tools. So you use them as a screening tool. You ask about illicit substances. Their social support. You document who is the patient's social support. You ask them about recent travel. Their sleep patterns. When you ask about sleep patterns, you are asking specific. How many hours a night do you get of sleep? Is it a restful sleep? Is it a broken sleep? You want to be able to document that. You ask about spirituality. You ask them about their religion. Any hindrances to any type of care based off of their spirituality. You ask them about their physical activity. You want to know the type of activity they are participating in. You also want to ask them how frequently. This becomes important because there is a certain number of hours that we should be participating in physical activity a week. This will help you to see if your patient is doing so. And then this is somewhere when you think about prevention and you think about education, you may want to talk with them about later on. You ask them about their occupational history. Are they working? If so, where are they working? Are they exposed to any type of hazardous materials? This will become important because remember, in a day of mental health, we also need to be assessing every patient for mental health wellness. You talk about in the social history about their nutrition. You ask them about their eating. This then goes into you thinking about prevention and education on the patient about their eating habits, knowing how much protein they're taking in, how much water, how much, if they're taking in caffeines, if they're taking in protein drinks, if they're taking in energy drinks. One of the ways that I utilize, one of the strategies I utilize to collect the information about nutrition is sometimes I'll just ask the patient to review the last 24 hours. What did they eat and drink? That helps to have a more aimed conversation later on about if I need to discuss with them about increasing their vegetables, decreasing their sugar intake, their soda intake, but a 24-hour recall. It also is the opportunity. Patients will tell you, oh, that's not normally how I eat, or it is how I eat. And then you can go from there. And if there's any other questions that you should ask that may be appropriate, their living situation. Are they homeless? Do they have somewhere to live? Do they have any problems performing their activities of daily living? Do they feel safe? One of the great things about the way healthcare is provided now, many of these screening tools are given to the patients before they come and see us. If that is the case where you practice, it's still your responsibility as the clinician to review those forms and then make your assessment accordingly to help you develop a plan, if necessary, related to any of the results of those assessment tools. But you are responsible for reviewing them and addressing it appropriately. Another aspects of your narrative history is your sexual reproductive history, if they are female or male. If they're female, you want to ask them about their OB history or their pregnancy history. And then you want to document that accordingly. There is a link there for you with that as well, that you can go on and think about how you should write that with the gravida, the term, the premature, the abortions, and the living children, GTPAL, and how you document that. You want to ask them about their number of partners, their practice preferences, last menstrual period for females, and maybe even when did they start their menstrual cycle, depending on what type of visit they're there to see you for, and their sexual satisfaction if they're having any issues. Asking questions in this section can sometimes feel awkward, but it is no different than asking in any other section. The way you get over feeling that this is awkward is practicing asking these questions on your family members and friends, and then recognizing this is part of the health that the prevention that you want to provide to your patients. And as you ask these questions, it will help you provide the best care for your patients. You may identify if you need to do STI check-in, if you need to do some education about safe sex practices. Do you need to do any education or maybe plan on any type of contraception use? Once you finish with your sexual reproductive history narrative, you then want to go to health promotions and immunizations. This is where you're asking them about their age-appropriate immunizations. When was the last time they had them? And you document that date. You want to ask them about their dental and eye exams and even their last complete physical exam, and if there were any abnormalities in any of those. Collecting this information on your patients will help you to determine what preventative care you need to consider with your patient, or to help you to be able to document that patients who may have other chronic diseases are doing okay in these areas. And then, of course, you conclude your health promotions and immunization questions with looking at the age-appropriate screening, such as pap smears, colonoscopies, PSA tests, maybe even low CT scans if they would have a history of smoking. But this is where you are evaluating that information. So I like to kind of start to wrap this lecture up by just giving you information about the narrative history for your review of systems. Now, we know that collecting the review of systems can be time consuming because there's a lot of questions you need to ask. A good way to language this section before you start asking the patient questions is, I know I've asked you quite a few questions from already, but what I'm going to do now is ask you a group of yes or no questions. So to each question, please just answer yes or no. If you answer yes, I will make a notation of it, and we will come back to it at a later time in this encounter. But right now, I just want you to answer yes or no because I want to get through all these questions so that I can try to provide you with the best quality of care. Okay? And then I will start right at the top with constitutional. And that's where you're like, are you having any problems sleeping? Any problems with your mental health? Then I would go right down from constitutional and go to their head. Any headaches? Any blurred vision? Any nausea? Any loss of hair loss? Any lumps? Any nodules in your head? But I will walk down each system. And as you can see the list here, then I would go to the eyes. Then I would go to their ears, nose, and throat. And then I go to their lungs. For me, I ask 3 questions at least in each system. If they have different health problems, like maybe they are have high blood pressure. I may ask them a few more questions in the eye section, in the lung section, in the cardiovascular section, in their skin section. So, or in the neurological section. So I can tweak it depending on what the complaint for that patient is, but at least 3 in each section. And I keep it and try to be direct with the patients. It's yes or no. And then I just make a notation of anything that they said yes to so that I know that if I need to come back to that. So as we think about doing a encounter with our patients, it's important to accurately collect the history from your patient. Accurate collection of information from your patient, which includes the subjective and the objective, will assist you as the advanced practice nurse in diagnosing and treating your patient. Because once you've collected all that information, you are now ready to then move to your assessment piece. What is the diagnosis that you have for this visit for your patient? And then once you accurately have your diagnosis and your assessment piece, you can then move to your treatment. Once you move to your treatment, there are 4 ways that I look at every patient. For every diagnosis that I wrote on my patient, I do 4 things. Is there a medication that I'm going to prescribe for that patient? If so, I am documenting it down with the dosage, the frequency. Is there any diagnostics or labs I need to do on the patient for that diagnosis? If so, I am documenting it under that diagnosis. The next is there any preventative that I need to do for this patient related to that diagnosis? If so, I'm documenting it. And the last one is, what is the education I'm providing to that patient? If so, I document it. And I'm specific with my documentation, even with my education. Did I give them a handout? Did I verbally educate them? Did I do both? I document it all. Did I have the nurse or the medical assistant come in and do it? If so, I document it. Did I have a social worker come in and speak with them? If so, I document it. And then I also make sure that I conclude with, what is my follow-up plan? When is the patient coming back to see me? I never leave my patient hanging. Is it 3 months? Is it 6 months? Is it 2 weeks? And that I verbally discussed it with the patient and the patient verbally acknowledged understanding. And if not, then what is our next step? And is there anything in the future that I need to know or prepare for? This may seem like a lot in your documentation, but we do live in an age where I may see the patient one day. The next time this patient comes in, they may not always see me. So I want to make sure that the clinician that comes behind me can follow my train of thought and my process for taking care of this patient. They don't have to guess at what I'm doing. And I do that because I would hate to be the clinician on the other end of seeing a patient and I can't understand what the clinician was doing. Also, if it's not documented in a clear and concise manner, it's going to take me longer to get through the patient visit. And the same thing if it's my patient that I was seeing and I don't document correctly, I am now setting my next colleague who may see my patient, setting them up for having to spend more time. I hope this was helpful for you as far as your doing an encounter with your patient. I know that it is a lot, but as you practice it, that's what helps you to get better and better at it. It's practice makes perfect. It is prior preparation prevents the poor performance. There's no easy way to get to doing a comprehensive examination on your patient appropriately without practicing. And then once you know how to do a comprehensive, you can then tweak that comprehensive, adjust it to what type of visit that patient is coming in for. I will do another lecture talking about the difference in the type of encounters that a patient may come see you for and what that should look like.